at the Mount Sinai Hospital. She is a world-recognized leader in menopause care. She's a past president of the Canadian Menopause Society. She serves on the board and the executive committee of the International Menopause Society, and she also co-leads the education committee. She also directs a very unique fellowship program in mature women's health and menopause at the Mount Sinai Hospital, and is the recipient of the first Carol Mitchell Chair in Menopause at the University of Toronto, Mount Sinai Hospital. It gives me great pleasure to ask Professor Wendy Wolfman to take the virtual podium, share her slides, and her lecture, at the end of which we will have time for interactive question and answers, as we usually do. So,
thanks.
I would ask one more thing. I would ask you, I'm going to hide my video so we don't show up on part of her slides. But then when she's done speaking, as many of you as can, please put your video back on so that we can see and be interactive. Take it away, Wendy.
Thanks so much, Steve, for that kind introduction. Okay. How's that, Steve? Does it look good?
Perfect.
Okay. So I'm really delighted to meet you and to have people from all over the world attend. Only the International Menopause Society could get everybody together like that. And today I have the honor of presenting on non-hormonal options for vasomotor symptoms. And I hope that we'll make this a bit interactive, and there will be a lot of time for questions at the end. So these are my disclosures. I think Steve went through some of them. I have worked on some advisory boards for pharmaceutical companies. So the objectives today are to review both the IMS and the Menopause Society formal recommendations on validated options for non-hormonal treatments of vasomotor symptoms. We're going to discuss some clinical situations where non-hormonal options may be recommended for symptomatic women. And by the end of this, I hope that you'll feel confident in formulating effective non-hormonal therapies for your symptomatic menopausal patients. So we're going to start with a patient. She's 52-year-old gravida 2 para 2. I'm sure you've seen many patients like her in your practice. She's freshly menopausal. She's experiencing 10 or more hot flashes a day, many of them occurring at night. She's irritable, exhausted, and she's finding difficulty functioning at work. Unfortunately, she was diagnosed with ER-positive breast cancer 2 years ago, and she's currently on an aromatase inhibitor, and she wants to stop that therapy because her quality of life is so poor. She has a normal BMI, a normal blood pressure, but she says, can't I take natural therapy to make these things go away? And so what advice can you contemplate giving her? So in the background of this, remember that when we see menopausal women, it's really a very important time of life. And when they present, they have both symptomatic and in the background, asymptomatic things happening. So the first thing is dealing with the symptoms. It's important to validate those symptoms and take them seriously. The validated symptoms are vasomotor symptoms, night sweats, mood changes, sleep disruption, joint aches, and genitourinary syndrome of menopause, and a lot of the bladder, vaginal, and sexual problems that we see from that. Some articles have said there's over 30 perimenopausal symptoms, but many of those have not been validated. And remember that now the newer results from the WHI confirm the safety of hormone therapy in healthy younger women with no contraindications. You should be aware of the contraindications for hormone therapy, but actually they are very few. Also be aware of multiple options for the treatment of vasomotor symptoms. And I just want to say a word about what's going on in the background asymptomatically for women who are freshly menopausal, that many health issues start during the perimenopause. We know, for instance, deposition of visceral fat, acceleration of bone loss, increase in metabolic problems. Those all start in the perimenopause, the last year, right, or last year or two, right before the last menstrual period. And so when we're talking to patients, we always counsel them on the American Heart Association Healthy 8 Habits, including optimizing blood pressure, glucose, exercise, diet, lipids, not smoking, and getting good sleep. And also things that they can do to improve bone, such as adequate calcium in their diet, vitamin D, weight-bearing exercise, and for all women, regular exercise if they can. Okay. So what are the recommendations from the International Menopause Society? And I will refer you to the article in Climacteric in December 2025 and review statements in April 2026, going through all this wonderful document that we worked together on to develop, which was an update on the 2016 document with respect to recommendations for, in the new document, up to 30 different aspects of menopausal health. Remember that menopausal hormone therapy is the most efficacious and safe option for symptomatic women under the age of 60 or within 10 years of the last menstrual period. This is an individual therapy, however, considering the patient's symptoms, her health risks, her family history, her treatment goals, her preferences, and her last menstrual period, and unfortunately, whether she can afford the medication. However, older non-hormonal therapies, which actually are not approved, many of them, such as antidepressants, gabapentinoids, oxybutynin, may offer some relief, but they also have adverse side effects, and there are none of those that are effective as hormone therapy. However, in the last 2 years, the newer neurokinin receptor antagonists provide very effective treatment, which is slightly less than hormone therapy, but very efficacious nevertheless. There is no good scientific evidence for any natural health product. But what's the reality? How many people are actually taking hormone therapy? Well, we know that the Women's Health Initiative in 2002 was our tsunami, and after it occurred, the use of hormone therapy declined by a third. Continuation rates dropped. 50 to 80% of North American women choose not to take hormone therapy, either due to fear, or they believe it's not natural, or a lack of personal or provider knowledge. And so the latest articles, this one from 2024 from JAMA Network, found that only 5% of US women were currently using hormone therapy, although some of the numbers have increased in the last 2 years. So what are the contraindications to hormone therapy? Undiagnosed vaginal bleeding, estrogen-sensitive tumors, active liver disease, active thromboembolic disease, some of the thrombophilias, but now we can use in some of them anticoagulants, acute cardiovascular disease, recent stroke, and porphyria. Non-contraindications to hormone therapy in contrast to oral contraceptives include smoking, diabetes, hypertension, migraine without aura, and using hormone therapy with caution in women who have gallbladder disease, increased triglycerides if they're on oral therapies, hepatobiliary disease, migraine with aura, or who are at high risk for cardiovascular disease or breast cancer. These are the recommendations from the what used to be called the North American Menopause Society, which now is called the Menopause Society. It's the position statement from 2022, and it is an excellent document as well. So they divided the non-hormonal therapies into 3 groups. The first group were recommended therapies which have good and consistent evidence, scientific evidence, and they called those level 1 and 2. And those include SSRIs, SNRIs, GABA, pentanoids, fezolinetant. At that time, elinzanetant was not available, cognitive behavioral therapy, hypnosis, and oxybutynin. Their second group had limited or inconsistent scientific evidence, level 2, or level 3, which was consensus and expert opinion. And that included weight and ganglion blockade. What they did not recommend, insufficient or conflicting data, were yoga, cooling techniques, dietary modifications, paced respiration, relaxation, stress reduction, avoiding, and some prescriptions such as clonidine and pregabalin, which previously had been recommended, and suvorexant. And then all the other herbal things such as evening primrose oil, black cohosh, soy preparations, and over-the-counter supplements. As well, they listed acupuncture there, although there is some data for electrical acupuncture and chiropractic interventions. Now you can see here that they graded all of them, and this included consensus opinion. So here's your patient. She tries avoiding spicy foods, although there's really no good data either for triggers. But some patients will say, I always get a hot flash after I have a drink of alcohol. So avoiding it is a good idea then. She lowers the temperature of her room. Her house is freezing. She dresses in layers. She eats more soy. She reduces alcohol intake, which is a good idea for everybody. And she lost 5 pounds. She starts a yoga class. What's the data, and will this actually work? So let's start with lifestyle options, level 2 or 3. Dressing in layers, environmental controls, lowering temperature of the room, forehead cooling device. I once was giving a lecture and a family doctor said, the only thing you need is moisture wicking sheets. So there are all sorts of devices and things out there on the market. Now that menopause is a money-making event, everybody's getting on board. Spend much money on all sorts of things to try and control hot flashes. Avoiding triggers such as alcohol, caffeine, spicy or hot foods or liquids. There are really no good studies that avoiding triggers alleviate vasomotor symptoms. Now, this is common sense. If your patient says, every time I drink, I get a hot flash, I think you can advise her it's probably a good idea for her not to drink so much. What about dietary modifications? The research is really limited. Definitely, it does no harm. There are surveys showing that people who ingest more vegetables, fruits, and vegan diets have fewer menopausal symptoms. There's a longitudinal cohort study showing that women who ingest high-fat and sugar diets have an increased risk of vasomotor symptoms. Another study in women who had higher soy milk and veggie consumption had fewer menopausal symptoms, whereas those who ate poultry and skimmed dairy products had worse symptoms overall. But I think, these are sort of motherhood statements. Good to follow a Mediterranean diet. But the data for actual severe hot flashes or moderate hot flashes isn't really there. What about weight loss? Well, this is recommended. Again, no harm, good idea. Obese women are more likely to report more frequent and severe hot flashes. There are some randomized control trials showing that weight loss is associated with a decrease in vasomotor symptoms. And adiposity may act as a risk factor for vasomotor symptoms in the perimenopause, but not so much when women are older. There is limited evidence that suggests weight loss may be used to improve vasomotor symptoms for some women, and therefore it's not a bad idea to consider. And remember, of course, that losing weight provides health benefits beyond treatment for vasomotor symptoms. What about exercise? Again, there are other health benefits besides vasomotor symptoms. Observational studies have suggested that women who exercise have fewer symptoms, or other studies show at all. Remember, triggers sweating, and for some women, this temperature change can be associated with a sensation of hot flashes. There are several Cochrane reviews showing poor evidence for exercise. For instance, there's systematic review and meta-analysis of 12 randomized controlled trials of over 1,300 women showing no real benefit. And as well, the studies on yoga show limited benefit compared with exercise or nothing. Okay, so our patient goes to the health food store and comes back with a bag of goodies. What do I mean by that? She comes to the office with a shopping bag full of stuff she's bought, maybe over $1,000 she spent. Some of the things: soy, equal, pollen extract, evening primrose oil, maca, rhubarb, and wild yam. She wants to know if these will work and when they will work. Before I moved back to Canada, I worked in the US, and one day a woman came and said, "Oh, I got this stuff in the health food store, and it's amazing for my hot flashes." And I said, "Oh, okay, do you mind bringing it so I can look at it?" So when she brought me the bottle, it said mashed up pig ovary. And that's part of the problem with these supplements. There is lack of regulation about purity and safety. There are limited, rigorous randomized trials, for instance, with black cohosh. Some signal for benefit in various studies, but many of the studies were not prolonged. They were of short duration, and there were studies on both sides. There were some reports of liver problems in people who took too much, but in general, it's probably not dangerous and may provide small benefits for some patients, but for severe hot flashes, it's not really going to do the trick. The numbers in these studies are small as well. Similarly, there are like 10, 15 patients in studies, some with placebo-controlled, some without, for many other herbal remedies. So right now, we don't recommend black cohosh, ginseng, thistleberry, wild yam, dong quai, chasteberry, milk thistle, vitamin E, rhubarb, and cannabinoids. There are not a lot of good studies yet. So after 6 months, she comes back and she says, I've had no improvement in my hot flashes. What will actually work? And how long is this going to go on? Because otherwise I'm going to stop my aromatase inhibitor. So the mean duration of vasomotor symptoms is 7 to 9 years. For a third of women, they last more than 10 years. There are ethnic differences. In the study of women across the nation, they were greatest in African American women, followed by Hispanic, Caucasian, with the lowest being Asian women. 40% of women still have hot flashes over the age of 60, and 6.5% of women, they're moderate or severe. There's another study with a systematic review for women over 65 suggesting 20 to 45% of women still have hot flashes, and almost 18% reporting that as severe. Older data, however, suggests that only 10 to 15% of women still experience troublesome hot flashes into their 70s. And in my clinical experience, that's probably about right. So there is data for clinical hypnosis. This is a deeply relaxed state. They use mental imagery and suggestion, and it's used to manage pain and anxiety. But there are several randomized controlled trials looking at survivors of breast cancer with significant hot flashes showing improvement in women receiving clinical hypnosis. And this was assessed by physiologically monitored vasomotor symptoms, and this was delivered both by trained staff or via smartphone application. Behavioral therapy, it's something sometimes we as physicians don't always think about, but there is very good evidence for it. There are randomized controlled trials, particularly in women with breast cancer, via group administered or self-guided, both in perimenopausal and postmenopausal women, showing 65 to 78% improvement, and then with maintenance at 26 weeks. There are 2 trials also in breast cancer survivors administered by nurses showing reduction in vasomotor symptoms. And there is another trial where it was delivered via internet with and without therapist support showing efficacy. When they had a program of CBT with physical exercise, the physical exercise alone did not reduce the vasomotor symptoms, but the cognitive behavioral therapy did. So always remember this. In our area, this can be administered either by psychologists. There is a workbook online by Cheryl Green, and there you can train your staff to provide CBT for your patients. Now, SSRIs originally were tested also in breast cancer survivors. They are recommended as level 1, but remember, these are not approved in Canada or the US, and I'm sorry, I don't know about other countries around the world, for treatment of hot flashes, except for one that I'm going to discuss in the US. There are meta-analyses, Cochrane reviews, and applied for survivors of cancer or menopause that has occurred naturally or surgically or as a result of cancer treatments. There is a reduction of vasomotor symptoms of 25 to 69%, also improvement in severity frequency from 27 to 61%. These include paroxetine, escitalopram, citalopram, venlafaxine, and desvenlafaxine all have shown significant reduction in vasomotor symptoms in large, double-blind controlled trials. Duloxetine has shown reduction in smaller studies. Sertraline and fluoxetine are not recommended. And remember, if you have a patient who also has predominant mood symptoms, then they will provide benefit for mood. But there are also some adverse events, especially if these medications, if the dosage is pumped up, you can get weight gain. You can also have development of vasomotor symptoms at high doses of SSRIs and higher with SNRIs. If you withdraw these medications abruptly, you can see severe mood withdrawal symptoms and also other issues. Also, SNRIs, if you withdraw, may increase blood pressure and use those medications with hypertension. And remember that citalopram and escitalopram may cause QT prolongation. So, paroxetine is the first non-hormonal FDA approved for treatment of moderate to severe vasomotor symptoms. It's been shown to improve severity and frequency for 24 months without sleep disruption and without weight gain or negative libido effects. Rarely you can see some of the other side effects of SSRI, such as nausea, dizziness, or even suicidal thoughts. But my experience with the low dose of Paxil is that it's very well tolerated. And you can even stop it without any significant tapering. However, it's not recommended in women who use tamoxifen, and that's because it can lead to inhibition, which is the enzyme that converts tamoxifen to endoxifen. So a safer choice for a woman who's on tamoxifen is venlafaxine, desvenlafaxine, escitalopram, or citalopram. What about the gabapentinoids? So gabapentin is an anti-epileptic. It's been used for many, many years for chronic pain, diabetic neuropathy, and neuralgias. It has been shown to improve the frequency and severity of vasomotor symptoms at 900 milligrams or 300 milligrams 3 times a day, up to 2,400 milligrams in divided doses. Typically, the way we prescribe it is we usually prescribe it once a day. Allow the patient to increase it. We start low, maybe at 100 to 200 milligrams, and we tell the patient it may not work, so my permission to increase the dosage every 2 to 3 days up to 900 milligrams. Now, the biggest side effect with gabapentin is dizziness and drowsiness and feeling hungover. It's worse during the first week and it improves in the second week and usually resolves after a month. But patients often don't last that long. And so what I tell them is that gabapentin has a short half-life. It lasts 6 to 8 hours in the body, and that's why it's often dosed 3 times a day. And you can be a fast metabolizer or a slow metabolizer. So if you take your dosage at bedtime and you feel hungover the next day, just move your dosage closer to your dinner. As I mentioned, it's quite a good medication for women with sleep issues. And currently we do not recommend pregabalin. There are more adverse events. In some places it's a controlled substance. So currently it's not recommended. Now, there are studies pooling and looking at all these different therapies. One of them was the Miss Flash trials of over 1,000 women looking at the use of estradiol, antidepressants, omega-3s, cognitive behavioral therapy, yoga, or aerobic exercise. And the conclusion was that for those with the most serious and bothersome symptoms, estradiol was the best. If it was mainly vasomotor symptoms and insomnia, there was good improvement with CBT-I, specifically for insomnia, CBT. If the patient's main problem was vasomotor symptoms and psychosocial complaints, the best improvement was with antidepressants or CBT-I. With exercise or yoga, there were smaller improvements and not recommended by itself. And over the literature, there are very limited studies head-to-head with estrogen. What about oxybutynin? Oxybutynin, as we know as gynecologists, is a bladder drug. It is anti-muscarinic and anticholinergic, and therefore it has side effects consistent with its action, including dry mouth, difficulty urinating, and abdominal pain. As I mentioned, it's used for overactive bladder and urgent continence. However, it does have in these two studies very good reduction in frequency and for vasomotor symptoms, but it's not commonly prescribed because of its side effect profile, and it's been associated with cognitive decline in elderly women. And like many of the SSRIs and even gabapentin for treatment of vasomotor symptoms, it's an off-label use. Clonidine was a commonly prescribed medication. It's a centrally acting alpha-2 adrenergic agonist, slightly more efficacious than placebo, but its efficacy is less than the SSRIs, SNRIs, and gabapentin. And it can also have adverse side effects, including hypotension, lightheadedness, headache, dry mouth, dizziness, sedation, and constipation. In a Cochrane review, there are inconsistent results, but still superiority to placebo. And sudden stopping has been associated with a significant increase in blood pressure, and therefore it was taken off the list of effective therapies and not recommended. Nothing works for this poor woman. What are we going to do? And in the past, very, very difficult. However, in the last few years, we now have the neurokinin B receptor antagonists, and this is based on physiology that was discovered about 2008, 2013, looking at candy neurons. Now, a female neuroanatomist was dissecting cadavers and found these cells in the infundibular nucleus of the brain in postmenopausal women that were hypertrophied. And they were not hypertrophied in premenopausal women. So she postulated that they might have something to do with menopause. And when they looked further, they found these cells elaborated kisspeptin, neurokinin B, and dynorphin. And there had been work before on kisspeptin in children who did not go through puberty. And it was found that kisspeptin triggers GnRH release and as such increases LH and FSH. When there is no estrogen or that estrogen starts to decline around menopause, it takes the brakes off these cells, these candy cells, and they begin to enlarge and produce more neurokinin B. inappropriately, because basically their control for that has been disrupted. So I talk about the inappropriate stimulation as a result of lack of estrogen. What was discovered is that these medications that block this neurotransmitter can have a significant effect on hot flashes. And so the other part of this arc is when these cells enlarge, they stimulate the thermoregulatory center within the brain, and then there is stimulation of all the physiologic mechanisms with vasodilatation and heat dissipation and then sweating. We are mammals. We are obligated to keep our temperature within a narrow range. This thermal regulation is a very basic mammalian attribute. And when there's estrogen there, this whole pathway is kept under control. But when there's no estrogen there, then there's the inappropriate stimulation of your thermoregulatory center. So the first neurokinin B receptor antagonist that was released is called fezolinetant, and it is a neurokinin B receptor 3. And there are 3 phase 3 trials. Skylight, that should be 1, 2, 4, which have shown efficacious, safe, and well-tolerated medication. The dosage of 45 milligrams reduced daily moderate to severe vasomotor symptoms by 62 to 80% at 4 weeks versus 39%. You can see all these placebo trials have quite a high effect for placebo, and they also reduce the severity of the hot flash. By 12 weeks, there was 74 to 87% reduction versus 55% for placebo, and this effect was sustained through 52 weeks. There were also some benefits on sleep, but this was not a primary outcome measure. There was a low incidence of side effects, those being headache, nausea, abdominal pain, and GI issues, all less than 10% or 5%. And in Skylight 4, there was no effect on endometrium or bone. However, in post-marketing data, it was found there was a 2.3% elevation in transaminase, and there were a few very serious liver problems, and therefore many countries have recommended that liver function tests need to be monitored at baseline 1 month, 3 months, 6 months, and 9 months. In some places, it's baseline 3 months, 6 months, and 9 months. The medication is contraindicated in those with cirrhosis, severe renal disease, and those on CYP1A2 inhibitors, such as fluoxamine, fluoroquinolones, and estrogens. And there is an ongoing trial currently in breast cancer patients. This is just diagrams to show on the top one frequency, on the second one severity, and the gray bar is the placebo, and these are dosing studies. And you can see the really rapid reduction in hot flashes here, about 6 or more or less hot flashes a day. And you can see that at 12 weeks, there's usually a crossover where they put patients who are taking the medication on the patients who are taking placebo, they cross over to the medication. And you can see then, even for the so-called placebo group, that the number of hot flashes became superimposed on the women taking the medication, but they themselves now are also taking the medication, and that this has been sustained out to 52 weeks. The second drug is called elinzanetant. It's a dual neurokinin B receptor 3 and receptor 1, which probably activates substance P. And it's been shown to be more beneficial again versus placebo, again for both frequency and severity, with a rapid onset within 1 to 2 weeks. It has been shown to have beneficial effects on sleep, analyzed via the PROMIS questionnaire, as well on quality of life. Also, they have a 1-year study of breast cancer patients called OASIS 4 that was published in the New England Journal of Medicine last year, showing equal efficacy and similar efficacy as for women who did not have breast cancer. And those patients in OASIS 4, I'm going to show you, about 40% were on tamoxifen, and they also had to have an equal number on aromatase inhibitors. And again, there was sustained efficacy to 52 weeks, 120 into divided dosages. Have been some systematic reviews, both for fezolinetant and elinzanetant, showing reduction of vasomotor symptoms of about 50%. We currently have no trials comparing these medications against estrogen, nor do we have trials looking at estrogen plus these medications. And these are the diagrams for elinzanetant, looking at mean change above in number of baseline hot flashes. You can see by week 4, almost 7, and week 12, almost 8 reduction in the number of hot flashes. And you can see here frequency, and this was dosing studies looking at 120 and 160 milligrams for changes again in baseline, as well as frequency and severity. And we also know that there is improvement in sleep and in quality of life. So these were the women who enrolled in OASIS 4. They were ages 18 to 70. They were receiving tamoxifen or aromatase inhibitors with or without GnRH analogs for the treatment of estrogen receptor or hormonally receptor positive breast cancer. The enrollment was designed to have at least 40% of participants receiving tamoxifen and at least 40% receiving aromatase inhibitors, and you had to have at least 35 moderate to severe vasomotor symptoms per week. And they had significant exclusions in that trial. In terms of this study, elinzanetant met all primary and secondary endpoints in phase 3 for treatment of moderate to severe vasomotor symptoms. The side effects were somnolence, fatigue, nausea, and headache, but none were serious, and there was no marker for liver function problems. As I mentioned before, there is a study called Highlight 1, double-blind placebo-controlled phase 3 clinical study, which is ongoing to assess efficacy and safety of fezolinetant in women with stage 0 to 3 breast cancer, hormonally receptor positive, on adjuvant endocrine therapy as well. And we'll await the results of that trial. When you compare the two drugs, which is better, this is something called a matching adjusted indirect comparison. You can see that for frequency, fezolinetant was actually numerically superior, but severity were similar. Sleep disturbance was improved by both, but more for elinzanetant. And for quality of life, they were pretty similar. So it's hard to say which is better. I think that so far elinzanetant does not have a signal for liver function problems. And we need to also see their post-marketing data. But they both are very good drugs and should be considered. Obviously, sometimes for patients, cost is an issue. So just to review, the non-hormonal medications for vasomotor symptoms include the SSRIs, the SNRIs, and these are the dosages that are recommended: gabapentin, oxybutynin, slow-release oxybutynin is recommended as well, fezolinetant, and elinzanetant. Lastly, just a word on stellate ganglion blockade. You can see in this picture that it's an invasive procedure. It usually is performed by an anesthesiologist. Before we had the neurokinin B receptor antagonists, we did perform it on several patients with mixed results. It doesn't have prolonged effects. It's an injection at C6 to T2 in the anterior cervical spine. Its exact mechanism is unclear. You inject bupivacaine, and there is a study looking at this trial versus sham for vasomotor symptoms, actually measuring skin conduction, showing 45 to 90% reduction in vasomotor symptoms. And there was a trial comparing the treatment with paroxetine 7.5 milligrams over 6 weeks. Both treatments had an equal efficacy on frequency and severity of hot flashes. However, rarely you can run into serious side effects such as hemorrhaging or seizures. So you have to be a little careful. So in conclusion, menopausal women who experience significant symptoms have a variety of safe options for treatment. However, for women with moderate to severe symptoms, I think now we should consider the neurokinin B receptor antagonist first, after hormone therapy, because they're almost as effective as hormone therapy. Your treatment and decision is a shared decision between you and the patient. It depends on the patient's symptoms, her medical risks, her issues, her preferences, and whether she has coverage. But remember that there are now many non-hormonal therapies for women who prefer not to take hormone therapy or who have contraindications. I thank you very much, and I'm happy to take questions.
That was wonderful. And if you can stop sharing your screen and people want to put their video up, would be great if you can. First of all, a couple of comments, and we'll get into some discussion. I'm really glad that you went into some detail about the SSRIs and tamoxifen and the CYP enzyme system, because I think a lot of people aren't aware that different SSRIs have a different effect on that and can affect the effectiveness of the tamoxifen. So, and the irony is that's really how all that stuff got started. In other words, in the very beginning, women who were on tamoxifen have some of the worst vasomotor symptoms, and people out of desperation were giving half-strength SSRIs before there was any of the studies with paroxetine to get it approved. And I think that the information about the potential of some of these on the effectiveness of tamoxifen goes unknown. So I'm really glad that you went into that in detail, because I find that is somewhat lacking, especially among some of the oncologists that we work with, who kind of hand out SSRI sometimes to those patients. The other comment that I was going to make, it seems, most of us are really concerned, at least in the US, and I assume Canada is the same. The supplement business is just the wild, wild west. I mean, it is unregulated. What exactly is in what you're taking is up for grabs. It is just not controlled. Recently, the people, I mean, I know that when it was first introduced into the US, there was a product called Relazin, which has a whole lot of different names. I think it's called Ceralis in some parts of the world. It's that purified pollen extract. But they have just resurfaced. I think it's been taken over by a French company now who's trying to reinvent it or whatever. I know I published an abstract on it because it does not interfere with tamoxifen. It's metabolized differently. But the reason I'm bringing this up is it came to my attention that in France, the supplements are regulated similar to how we regulate drugs by the FDA in terms of their purity and their process. And apparently, this is a purified pollen extract, but that is manufactured in France according to standards that don't exist in the US. And I was sort of unaware of that. So, there's a small randomized trial with it that I don't think has enough power, although, my biggest concern about some of these things is their safety. Obviously, anytime we talk about a drug, we're thinking about safety and efficacy. It's amazing. I often talk to patients. Every single trial with estrogen and every single trial actually with NK3s, there's a 40% placebo response. I would like to patent placebo so if I come along earlier in my career. So I don't know. I mean, if something is safe and a patient thinks she feels better, my safety's always been my issue. So I don't know if you have any comment about if supplements, and I don't know, this is a great form perhaps in some of these other countries. I was totally unaware that in France, there's much better regulation for some of these things, or if they're manufactured according to the French standard, apparently it's very different than it is here in the US. So, and many of our guidelines, like we've talked about, certainly the Menopause Society, it's very US centric, and Canada kind of as well. You have any thoughts on that?
Yeah, I think I alluded to many of the things that you mentioned. First of all, the money-making aspect of anything that will treat women's problems. And so I think women they don't want to take medication, but they'll take so-called natural therapies. So, and I think the fact that many of these are unregulated and the trials that are shown to you have small numbers of patients and poor regulation. I think Germany also has if we have anybody from Germany, maybe they could speak to that. I think they also regulate some of their supplements.
Yeah, interesting. All right, so I see some hands. Swabaj, I can never say your name. I'm sorry.
Thank you, Professor. My name is Suraj, and I'm from Nepal. Thank you very much for an enlightening talk, Professor Wendy. That was really, really very, very interesting. I have some questions regarding this off-label treatment like paroxetine, deoxetine, all these drugs, although it is not, I guess, approved by FDA, but can you still prescribe? One question is that.
Yes.
Okay.
Yes, anything that's off-label, we have, as a physician, you can write a prescription for. Yes, it's similar with testosterone, for instance, in Canada. You can write a prescription in an off-label way, as long as you discuss the risks with the patient.
Okay. Because we are having some issues that some of the drugs are not approved by our DDA, and then the farm, the shopkeepers, they don't want to bring in country. So I think this is a very good point for me to argue with them. Another question is about this. It looks like fezolinetant and elinzanetant. It's very difficult for me to pronounce. I haven't used in Nepal, and I need to find out whether it's available or not. So I wanted to know the the cost effectiveness between the hormone therapy and this? Like, is there a cost difference?
Yeah, so I think that's a great question. As I mentioned, there's no head-to-head trial yet. There have been calculations. They don't work as well, but they're almost as good. So we are just getting elinzanetant. Steve has had it for a year, so he can speak with more confidence than I can. We've had fezolinetant, which is quite expensive in Canada.
Yeah, the costs, I mean, I don't know. I think this is so variable country by country. Certainly in the US, when they introduce these new compounds, they often have coupon programs or people that have certain types of insurance pay a minimal amount, but if it's totally out of pocket, it's really exorbitant. It's all over the map, at least in the States, for all pharmaceutical products. There's so much variability. It's a shame. And I sometimes think that the US is subsidizing certain other countries where they have stricter regulations about what pharma can charge. Here it's whatever they want. There really are no regulations from the government. But obviously there are many generic forms of hormone therapy. But once again, this depends on people's plans, but in general, they would be less expensive. And I know that a lot of these newer agents are not even available in some countries. So, I mean, the access that patients have, it's so variable. And that's why understanding perhaps things that might be cheaper that are off label that you might want to try if you're able to. I mean, before the NK3 drugs that we talked about were available, I had reasonable success with gabapentin with about a third of the patients. About a third of the patients did not tolerate it at all, and about a third of people found it good if they only took it before bed. And there is some data, where there was a head-to-head trial with it against estrogen, and it did quite well if people tolerated it. So, I think that, and it's, at least in the States, it's amazingly inexpensive. So it's totally variable. I mean, I have a lot of patients who I've given them a sample of elezanitant because they give you a little box. It's good for like 12 days because it works very, very quickly. So I've said to some patients, try this. And if you feel within 12 days that it's really helpful, we can look into, can we get you a reasonably priced prescription depending on your plan? But it's totally variable. Stella, hand up. Next.
Yeah, hi. Thank you, Wendy, for your talk. I also like to ask a little bit about the neurokinin 3 receptor antagonist because it's recently available in Singapore. So you mentioned that we have to monitor the liver function test at 0, 1, 3, 6, and 9 months. So beyond that monitoring, beyond 1 year, how often do we need to monitor the liver function test?
Yes. On the medication so far is up to 52 weeks. So there's no long-term information, but there was a signal if you were having a liver problem for it to occur around 77 days, like quite early after you initiate the medication. So the thought is that if it's okay, maybe just you can reduce the frequency. But I'm speaking off the top of my head, because there's no data beyond a year.
It's also very interesting. There was an NK3 drug that never came to market because there was significant liver problems with it.
Yeah.
So when fezolinetant started, they had a separate data safety monitoring board for just liver looking at it. And when it originally came out, it didn't have quite as stringent requirements. It was
Right.
post-marketing materials that there was, especially at first, there was just one case of pretty severe, liver involvement, and he wasn't even 100% sure that it was due to the drug, and then they changed the label for this kind of labeling. I think the most important aspect is, number one, don't want to give these drugs to people who have known liver disease, and B, they need to be on the lookout for anything that might suggest that they've developed some abnormality in the liver. But even people who just elevated their liver function tests, some of them normalized even without stopping the drug, and virtually everybody who stopped the drug renormalized their liver functions. And it is the other thing that's been perplexing to all of us is we thought that the elezanitant would get class labeling. You know, the FDA seems to do that in the States for lots of things, and yet its label relative to the liver was very different. It doesn't have quite the same requirements, and in the trials seemed to have very little effect on liver. So
But we don't have post-marketing
Right.
data
that's
either.
what I'm saying.
So,
It'll be
you know,
interesting to see if that ends up
phase-
the same way.
who knows, right?
I mean,
So,
part of the problem with trials is, the healthy patient bias. People who enter into trials are not always necessarily indicative of the real world. So my biggest issue is you want to make sure you don't give these drugs to people who have or may already have some underlying liver abnormality, for sure.
I do want to say so a monoclonal and for neurokinin on trials that look very good too. So that's a month injection. That too.
And you
Hi,
need,
Elizaveta.
you need
Yes.
there you go.
Hi, thank you. I'm one of her graduate menopause program. Yeah. Thank you. I just wanted to ask, to my public